Well, good afternoon. Welcome back to the after lunch hour. So this is the nap hour. I know how this goes, but hopefully you all are enjoying the day and getting ready for maybe a huge Purdue upset tomorrow. I see some laughs. I also know basketball starts in about 7 weeks, so that's our hope there. But it's a pleasure to be with you this afternoon for our breakout. So this is the rural health breakout, and then the main room breakout is migrant and Latino health are the two main topics. So for those of you who don't know me, I'm seeing a lot of familiar faces, but my name is Dr. Cody Mullen. I'm a clinical professor here in the Department of Public Health and one of the associate directors of the center. Prior to that, coming to Purdue, I worked for the Indiana Rural Health Association and did that work. And actually, my co-presenter is the person that introduced me to National Rural Health and Indiana Rural Health Association. So I credit a lot of my career to this gentleman. But you've heard from Tim in our panel as well. So he's going to be saying the things that I can't say per Indiana legislation. No, just joking. But he's going to be giving the on-the-ground information from the data. So shout out, some of the work that we're going to present was funded by our Indiana State Department of Health, State Office of Rural Health, their FLEX project. And we did have a doctoral student who also already has a doctorate, so Dr. Jane, work on this data. Andrew Weber, who earned his MHA back in August, and then Susan Grisham, who's running around as well. So where are we going to go during this session today? I know we have a wide experience in this room. Some of you are very new to healthcare. Others of you could give this presentation. So what we're going to do is we're going to start with some level setting of where are we now as a country when it comes to healthcare. Healthcare, specifically rural health. We're then going to do a mini deep dive into the three main payers that we work with: private health insurance, Medicare, and Medicaid. We're then going to talk a little bit about some rural data that we've analyzed here at Purdue as part of the center and some of the takeaways we have from that. And then lastly, we're going to have a discussion of where we go from here. Tim is going to interrupt throughout as he has insight to share. But we also want this to be a discussion. So if you have questions, if you have thoughts, please push back on either of us. We do have, like other room, a mic, mainly for the recording purposes, but please feel free to raise your hands on that. But before we start, I always like to start and end a presentation with some imagery. So I have an addiction. I know the first step is admitting, but I love to go on cruises. That is one of my favorite things to do. I've been on 6. I got one 4 weeks from today. I leave for the next one. But I took this picture back in October coming back from a cruise. And this is over, for those of you who know Indiana, between Kokomo and Logansport. 31 was out the other side. Logansport here. It was mid-October. Anyone know what was happening in November of last year? Early November of last year. Anyone remember? An election. Okay, presidential election occurred in November that we knew no matter which direction it went at the time, things are going to change. If we went towards the Harris or to the Trump administration. And we're in between these clouds as we started our initial descent, looking down, and I was really reflecting back on where we are in health, public health, and healthcare. We're at this point where there's this community underneath us that we're here to serve. We have our seatbelts on because we're bracing for the turbulence. But there's pure beauty looking at these two layers of clouds. Now, I'm a public health person. I don't know what these clouds are called. That's the Earth and Atmospherical Science Department. They can talk about all that stuff. But to me, it was just a beautiful picture. We're going to come back to this at the very end. So where are we as a country when we look at healthcare delivery? Well, healthcare is expensive. If you listen to actuaries, you listen to economics and economists talking, healthcare costs too much as a ratio of what we spend in society. If we look at the most recent data, which 2023 is the most recent, Health Affairs should have a new article mid-December with 2024 data. But we are hovering, minus the pandemic timeframe, about 17.5% of GDP. So we round this up, because I like easy numbers. For every dollar that we spend, 20 cents is somehow tied to healthcare. If we think back to Carrie's presentation, 21% of healthcare is going to disappear with Medicaid. Coincidence? I don't know. But that's 20 cents that's not going to education. not going to childcare, not going to roads. We can all argue, right? I work in healthcare. My family uses a lot of healthcare. It's an important service, but it's not sustainable at the current growth trajectory. And we're seeing changes occurring from OB3, but we don't know what that's going to look like. And to be honest, I flipped out because I'm not super old, but old enough to remember when the ACA passed. And my notes from those webinars, and guess what? My notes are pretty similar 2008, 2009, 2010 as they were this past summer. And 15 years has passed. Where's that spending going? If we look at private health insurance, so I'm an employee of Purdue. Purdue pays part of my health insurance. I pay a portion. That's private. Medicare, for those of you, we care for our elderly, 65 and older. There's other populations that go on that. And we aid our poor and our disabled, or Medicaid. They're all growing. It's not that it's one area that we need to focus on. And if we look at rural healthcare delivery, they're disproportionately paid by Medicare and Medicaid. And who can control Medicare and Medicaid? Well, it's Congress and it's the state. Private health insurance is a little different because it's this plan or that plan. Medicare, it's Congress. One body makes the decision, or two equal chambers. We can get into all the schoolhouse rock stuff later. If we look at data moving forward, we're right here, 23, 24, 17.6, 17.7. Notice by 2032, which right now feels like a ways away, but I know it's not that far away, we're hitting that magic 20%. That number where economists are saying when we hit that, danger, Will Robinson, danger. Bad things will happen. We'll have to wait and see.
Is this where I insert color commentary?
It's when it, yes.
All right, I'm older than the ACA. There. I'm older than the ACA, so I remember when that was going to, but I remember being in my doctoral studies in 2015, and I saw the same chart, and by 2020, the gross domestic healthcare expenditure was going to hit 20% by 2020. Same chart. Every year, I've been waiting for it to get to this 20% number, and every year it hovers at 17 and change, 18, and things like that. So just from a historical perspective, the other thing I'll add is for people that are not familiar with Medicare and Medicaid, they're both have guidelines through the Center for Medicare and Medicaid Services, also known as CMS. We're not sure which of the M's they don't care about. Please carry on. You can guess which one of the M's they don't care about, but
if we look at our national or international perspective, amongst other developed countries, we spend a lot more. But notice that for a while in the mid-1900s, we weren't. And then we look at our outcome, right? Our spend is not producing an exponentially higher outcome. So back in December, anyone remember what happened in December of 2024 in health and healthcare policy that was major in the city of New York? Crickets. It's like when I normally teach. No. The assassination of the CEO of United Healthcare and the whole robust discussion of how much does healthcare cost. And the Wall Street Journal did a deep dive. Purdue students, you get Wall Street Journal and New York Times for free. So if you're like, where do I find some good news sources? Those are two that we get as your at Purdue.edu email gives you access to. Wall Street Journal, you just have to go through the Cranor Library, the Daniel School Library, that aged myself right there, to get access to that. But if we look at the spending at the consumer level, when I had my whole extended family over this past weekend, and we sat around the table, all 18 of us, talking about life, healthcare came up. Not because it's what I work in, but it's just what old people talk about. I kept a tally of what we talked about. It costs a lot. If we look at Consumer Price Index, it is growing exponentially more. If we look at our average deductible, back in 2006, 2007, it was about $500. Now the average deductible is close to $1,800. This inflates over then into rural healthcare. People can't afford their deductible. So in healthcare administration, we call that bad debt. The bill has been issued, the care has been received, that payment's not coming in because the consumer can't afford it. They have insurance, but they can't afford that deductible. We look at worker and employer contributions. Employers have taken a lot of that strength, but workers are paying more too. Purdue's open enrollment starts in a few weeks, right? And there's that discussion as our premiums are going to go up as Purdue employees or as grad students. So I love this article. This came out. Commentary?
Let me hit something on the deductible piece. That's specific to rural areas. So when you think about the healthcare that's delivered in rural areas, we don't do open heart surgery, we don't do brain surgery, we don't do nobody gets the $600,000 bill from the rural hospital. It's primary care stuff, it's minor surgical procedures, it's 2 days in the hospital with convalescent care, that type of stuff. When you have high deductible plans that don't cover the first 10,000 or something like that, and you're billing for cardiac surgery that's $250,000, they can write off, those hospitals can write off that $10,000 and it's no big deal. When the rural hospital has a $4,000 ER bill or a $12,000 inpatient stay, not covering that first $10,000 is a big deal. And a lot of these people don't have the ability, especially with the high deductible plans, to be able to pay that. So that's one thing that's been rural specific on this chart that we're seeing here, and it really has impacted, because of the low cost of care, kind of the lower cost services in rural areas, has impacted rural a lot more than it has urban. And I don't know that message gets out that much.
Thank you. We look at spending as a country. We think of regions, the Midwest, we're happy, right? We always joke we're the nice people that will hold the door for you without the funny accent. But if we look at how our spending is, this is from JAMA earlier this year. If we look at spending per capita is in the top in that purple color. The darker is the more we spend. Notice if we think of what our rural states are, where's the darker colors? If we look over here, this is Medicare spending, Medicaid spending, private insurance, and then out of pocket. Disproportionately, our rural communities have a higher spend, not because the care is not there, but other factors that we'll talk about as we get going. So you already saw this slide because I shamelessly stole this from Chartis from February of last year, or February of this year, when they presented at Carrie's event in DC. Rural hospital closures. It's not a topic we like to talk about. Indiana, we have been a state where it's not affected us as much as other states directly. Darker the color, the more hospitals have closed. The darker the color are probably also your higher probability that those are states that did not expand Medicaid under the ACA. So we look at that, 188 hospitals, so this is from February 4th from the Sept Center, have closed or transitioned, and they excluded out hospitals that converted to a rural emergency hospital, which we can get into that during the Q&A if we have time.
Talk about rural emergency hospitals, but one of the things, and again, it's like I talked about earlier, sometimes with the hospitals, this is the mortality slide. This is the one that died. The ones that were put into nursing homes and are shells of their former self are not on this map. They're hard to count. So it's the cutting services that's really, these they finally just gave up the ghost. And they're not doing, now we're lumping rural emergency hospitals in there and shutting down inpatient services, which again, we can go into that. But one of the challenges, do you know when a rural hospital, it's sort of a joke, but not really. When a rural hospital closes, it's when the CEO can't look the local banker in the eye anymore and float the loan to cover payroll. And that's when it closes. So they do everything in the world they can to keep the doors open until they just can't. Because the local banker knows that they've got 75 mortgages held by people that work at that hospital. They know what happens to the rest of the community and the property values and everything else, and it affects their bank. So they want everything to keep the doors open on it. So it's a hard thing. What's surprising to me is when I talk to people in the communities When these hospitals have closed, you talk to the mayor, we had no idea the hospital was going to close. No clue. Just one day it closed. I'm like, you had no idea, really? And part of this is the community's not engaging in their hospital. I worked with a hospital out west, and the community said, hey, we're seeing a 1-star quality CMS rating. We're hearing that the bills aren't being paid, the paychecks were a week late. What's going on? And the CEO was, everything's fine. Don't worry about it. Stay in your lane. They didn't, and they got engaged, and that hospital is now on its way back. But had the community close and turn their back on that, they wouldn't be open today. No doubt in my mind. So it really is about communities that become disengaged and communities that stay engaged.
So we look at those two, this is the mortality slide. Let's look at some of the morbidity of rural hospitals. So these are hospitals at risk of closure as of February or December of last year. So this is all before OB3, that analysis. NRHA is leading the way. It's coming out quicker than I could get into slide format, and it's changing. But if we look at hospitals, back in December, there's 432 rural hospitals at risk of closure. There's 1,500-ish rural hospitals in the nation. So that's about 25% of that. About 15 states, it's 25% or higher of their rural hospitals in their states, and half of those at risk of closure from non-expansion states, which there are, I believe, 8 to 10.
The scary part about this slide is a lot of the hospitals that you see in that 25% or higher rate were also dark in the previous slide. So not only have they had a lot of closures, they're apt to have more closures. And sometimes there's population issues. Like the ones in Vermont are typically larger rural hospitals. So, I mean, all the hospitals in Vermont except for one are rural, but they're generally larger. The ones in Kansas, Nebraska, Texas are typically smaller. The ones in Wisconsin, I will tell you, if you ever want to study the ones that are successful, look at Wisconsin, because they work together. And they actively seek to build their communities. It's like nothing I've ever seen, like no state that I've seen that has that. So you'll see Wisconsin be successful where others will struggle. There's other reasons why that, but the important thing to look at this is that we're not seeing a reversal of the trend. We're seeing these hospitals, and get on this list, you have to look at the financial metrics, the patient quality metrics, and things like that other put them at risk of closure, and it's been pretty accurate coming out of the Sept Center, the data.
Yeah, we did see a pause during the pandemic, 2020, 2021, when there was an influx of a lot of grant funds during the pandemic, but we've picked up as if the pandemic never occurred. Keep going on the life support train. So these are states where access to behavioral health care is difficult in rural. If anything, our need for services of behavioral health care services has increased across all generations, our pediatric population, our working adult population, our more older adult population. As hospitals are closing, what are easier services to close? Behavioral health is an easy one. Hey, I don't have to have this to be a hospital, and there's telehealth access, so maybe it won't be as harmful as if I were to close, for example, OB services for labor and delivery.
The scary ones you look at are West Virginia. When you look at the number of opioid deaths that have occurred there and the number of addiction issues and suicide and things like that specific to West Virginia, and they're low ranking for mental health professionals. And it's a real shame. I mean, there's a real two-tiered system when you look at a lot of this stuff in rural areas of the country versus urban. I mean, and now I want you to think about that 2-year difference in life expectancy and really put some color into why there is that 2-year difference. Suicide rates, overdose rates, trauma deaths, cardiac and stroke events where you can't get to definitive care very quickly, that type of thing is what's causing this. And there's nothing that I'm seeing in the OB3 legislation or anything on the board right now that's going to start to close that gap. We look at maternal mortality rates in rural area are that of some Latin American countries. You are safer delivering a baby in Cuba than you are in rural America. Was I the light color commentary? Sorry, I'll come up with some. I'll think of something lighter here in a minute and talk to you about it. Sorry.
I forgot to take out, we're not doing all the policy portion that I've done in other presentations with this, so we're going to skip over the 2024 election, especially on a recorded live stream channel. So now I want to do a deep dive into each of the payer sources. Private health insurance, Medicare, and Medicaid. They each have their own unique challenges. Tim came in early yesterday and spent the night, so we got dinner, and he was looking at the slides and like, really, you're about ready to go here? And I said, I think we need to. But I don't think it's going to be light color as we talk about this. So how many of you have heard of the RAND report when it comes to healthcare delivery? So I see a few shakes. A lot of students look at me like the RAND report, okay? And we're going to talk about this for a little bit. So back in about 2016, 2017, a group of large employers came together and said, hey, we think we're spending more on healthcare than we should. Can someone go out and do an analysis on this? And these were large employers who are what we call self-insured. We are standing on the property of one of these large employers. So by being self-insured, they each had access to their claims data. They didn't know, or they knew exactly, okay, when Cody went to, IURnet, we paid this much. Not what was billed and charged, but what was actually paid. So RAND Report did this simple ratio analysis, and I say simple, there's a lot of analysis there, of how much was paid on a private insurance plan claim, divided by how much would Medicare have paid for that exact same claim. So my mom, who's on Medicare, went in and had the exact same care as me, and they did their best to risk adjust. I see Tim itching. They did their best to risk adjust for different comorbidities. So if I went in as someone who ran marathons, my health care would be less than if someone who went in with 4 or 5 chronic conditions. Keep going.
Okay, yeah, and the Medicare allowed amount is a dollar figure pulled out of the sky. That's what a Medicare pays for this. It's not what it costs or what it's worth. It's what Medicare pays for it. So it's an interesting point. So what? Hospitals lose 20% on the care they deliver to Medicare patients. They lose far more than that on what they deliver to Medicaid patients. So if we all paid Medicare rates, we'd lose 20%. Now we can talk about Medicare for all or something like that, but Medicare rates are one thing, but then we've got the complexity of private health insurance, which has a completely separate set of rules. One of the things that makes Medicare nice is the rules are very clear, spelled out, and pretty much fair for the patients in the hospital. We lose money on it, but it kind of works out in the end. So yes, you would expect private health insurance claims to be higher in payment than Medicare for a not-for-profit system to break even.
So they did this analysis at the state level. There is a white bar here, not because I did not know how to format my graph, but because I did not want to call out any health system by name. If you go out and download this report, there is names there of these health systems. But they did the ratio, so 1.0 if everything was Medicare, and they did the continuum. So the lowest on inpatient and outpatient average was 1.21, and the highest is 3.7. This is data from 2014 to 2016 at the state level. The clear bars are rural critical access independent hospitals and rural independent PPS, so larger rural hospitals.
The other thing I'll say is, so why develop a report like this? What does it really mean? Why would you even do it? And what we've seen, this is from the hospital side, is we want data to negotiate prices with hospitals between for-profit insurance companies and not-for-profit hospitals. And that's what this data is for. So anytime the data is developed with a purpose, you need to ask yourself, Who funded this? Why did they fund this? Why do they want the data? So that is not pure data from that standpoint, and it's designed really to make not-for-profit hospitals look like they're greedy, money-grubbing kind of things, and the insurance companies look good. So it's recorded now. My insurance is now canceled, but hey.
So I added a red line here. So why even talk about the RAND report, right? This is 10 years old. This is a decade old. If I was reading a dissertation with decade-old data, I'd be like, does this even matter anymore? Well, that red line is a point that our state legislator, HB 1004, this year introduced legislation. It did not pass fully, that if hospitals charged more than that red line of a ratio of Medicare and private insurance for 3 or more years, they would lose their nonprofit status, which has significant ramifications to rural healthcare delivery or just healthcare delivery as a whole. There was a carve-out for critical access hospitals, rural critical access hospitals. There was not a carve-out for rural PPS hospitals. So why bring this up? Well, this data is a decade old, and it was still talked at our state house very actively this spring, winter, and spring.
Yeah, I remember having a discussion with a few legislators on this, and they said, so, look, you're price gouging. Why are you charging so much for this? And I said, this is a private negotiation that happens between insurance company and a hospital of what the insurance company will pay. And it's really one of those things that our prices kind of aren't based on this, but insurance companies have really wanted to go down there. We want to pay you a percent of Medicare. And that's kind of where that goes. But, honestly, if I'm a manufacturer in a small town with a rural PPS hospital, I don't want to move my business someplace else. I don't want to see the hospital close. The hospital comes to me and says, look, you're my only commercial insurance. I've got to charge more than that to break even, to keep this hospital going 24/7 in this town. And the employer might say, okay, yeah, that's a reasonable price to pay to keep me from moving my shop from where it is, lose all my employees, and start someplace else. Now, maybe they want to, maybe they don't, but it ends up being their choice. So now the hospital may not be able to make it at that. And it may be the one straw that pushes them from a vulnerable hospital to a closed hospital. Again, decisions made in Indianapolis without enough people in the room to hear crickets at night.
So the RAND study has been done 5 times since the initial one was done. The first time it was the state of Indiana. It was released in 2017. At the time, a lot of people said, hey, Indiana, we're not different, right? Expand the data. So in 2019, they looked at 25 states. 2020, pre-pandemic, they looked at 49 states. 2022, they looked at all states. They updated their method in 5.0. If you're interested in that, take my elective next fall. We'll do a deep dive into that with 49 states. Maryland is very unique. So they exclude Maryland a lot because of their uniqueness. Again, not going to get into that. But if we look at national trends from 5.0, 5.1, so this is data during the pandemic and right after the pandemic, 2020 to 2022. Again, if we look at that 100% as the benchmark of Medicare reimbursement, we're now getting up as a national average of 250, 260%, which is right at that threshold that our state legislator said, you go over this, you're going to lose your nonprofit status. If we line up all the states, because what does a good legislator like to do? They like to compare our state to everyone else's state to say, where's Indiana? We're in the upward tail if this is a quant methods class. So compared to other states, and there's a lot of discussion about, well, Indiana is different than Arkansas, Mississippi, and Michigan. But that is coming up a lot if we look at the private health insurance and the reimbursement on that.
I wish it was clean data that was, and that's the thing. It's tough to make. So policy decisions are being made by data that is a proprietary report. So I'll just toss that out there. It's probably not the best to go on, but it is worth having a discussion on. It's having worthwhile discussion that why is it 250%? What's the cause of that? We could solve this by Medicare and Medicaid paying close to what the costs are to deliver the care. But that's not where it's going. And we have cost shifted in this country that as Medicare and Medicaid don't pay the actual cost of care, commercial insurance has had to make it up to the point they're so ticked off about it, they'll produce this report, they won't give us access to the raw data, and show how much they're paying because they want to pay less. And the employers are like, we're paying so much for insurance that it's why we're not competitive internationally. And there's a reasonable discussion to be had about that. What it is, capping prices at hospitals, increasing hospital closures. I don't know if you realize this, but we have economist majors in the area. What happens if we have a lot of closures of hospitals? What do you think happens to this when you have a lot of closures of hospitals? It's a supply and demand thing. If there's one system left in the state of Indiana that is open, what happens? So, yeah, I mean, it's worth a discussion. It's worthwhile data to have a discussion. But I disagree with what they're using it for. But that's the cost shifting that's occurred in this country in order to keep not-for-profit hospitals viable.
So let's transition to Medicare. So that's private insurance. Let's look at Medicare and a lot of the changes coming in Medicare. So when we think of Medicare, if you have anyone on Medicare, I get this question, I'm amazed how many times people say, well, should I do traditional Medicare or should I do this thing called Medicare Advantage? Medicare Advantage is a private sector product, so Anthem, Aetna, United, any of those, who say we can do Medicare better than the federal government, so federal government pay us what you'd spend on Medicare and we'll take care of the rest. But we don't have to follow all the exact same guidelines, rules, and regulations that traditional Medicare has to follow. So in 2007, which is the most recent data, or longest data, is about 1 in 5 Medicare beneficiaries was on Medicare Advantage. Last year, we hit the tipping point where over half are now on Medicare Advantage. Tim just said Medicare pays 20% less than what it costs to deliver care. Medicare Advantage pays less than that. So if I'm a rural hospital, I'm getting less money on Medicare as it is, and I'm getting even less on Medicare Advantage, and it's the majority of my population. The way I treat this for the young healthcare people in the room, right, no offense everyone else, right, is my family's like, oh, I want to do Medicare Advantage. And I go, I will not help you in any of your medical decisions if you sign up for Medicare Advantage. And none of them have. It's been wonderful because it's causing a lot of harm to hospitals. Some hospitals are saying, we're not going to accept Medicare Advantage. We're just not going to do that. Well, the current administration sees a lot of value in this transition of public sector to private sector. And Dr. Oz, who's the administrator for CMS, was in his testimony during his confirmation hearing, spoke very highly and prolifically about Medicare Advantage.
Read the MedPAC report on Medicare Advantage. MedPAC's responsibility is to report to Congress how effective Medicare and Medicaid are. MedPAC independently looks at this, and I remember speaking to them several years ago, and they were for Medicare Advantage because it created opportunities for ways to improve Medicare. Let's look at some creative solutions to that and things of that nature. And they saw some fraud in it. Medicare by itself is a very efficient system. There's very little cost of bureaucratic oversight, and the rules are very clear. Medicare Advantage, it's wild, wild west. And a lot of things they've seen have been Medicare Advantage plans trying to make the patients look sicker than they are to increase their payment levels. And, they cover a patient until they really need something, and then they encourage them to fall back to traditional Medicare when they can transition to that. It's really, from a hospital perspective, someone that's talked to a lot of patients that need care, their Medicare Advantage plan won't cover. It's really not, no matter what Joe Namath says, it's really not a generally good insurance program for most people, especially when you need health care, when you need insurance. It doesn't cover the things many times that you need. The other thing is the complexity of the issue. When I first was a CEO, I had 7 different payment plans. I had Medicare, Medicaid, and a handful of commercial insurance. And all of them have a different set of rules, different formularies, different things that physicians had to follow. So I had 7 set of rules that I had to go by. Well, Medicare Advantage comes in, there's marketplace plans, there's a dozen different state level Medicaid plans. When I left a few years ago, we had 70 different plans, 70 different rules. So every time a patient comes in the physician's office, they're on a different plan. The physician has no idea what the rules are. So it's decreasing. So Medicare Advantage is one of those things that decrease the funding that goes to rural hospitals specifically. Rural hospitals lose about 6% on Medicare. Urban hospitals lose about 20. So should have clarified that. Medicare Advantage, they lose significantly more. And there's this very complex process for billing, coding, reimbursement, denials, and things like that. So it makes it adds to the administrative cost of hospitals tremendously. Where Medicare typically pays, here are the rules, this is what we'll pay for. The administrative burden for Medicare is much, much lower.
So we look at who is in these different plans. So we look at traditional Medicare, 29.7 million covered lives or individuals. Medicare Advantage just slightly higher at 29.9. So we look at Medicare with a Medigap, so that's a Part C plan that covers some things. Really good plans. You know, all 3 of my household who's on Medicare have those. A lot have that, or they are still working with their employer. So they're 65, they're pulling Medicare, but they're still employed, so they have that as supplemental coverage. They may be what we call a dual eligible, so they're qualified for Medicare and Medicaid, either based on age, income, or disability. And then there's about 3.2 million people who are on traditional Medicare with nothing else. If you look at Medicare Advantage, there's about 7 million individuals who are in that dual population, who are both on Medicare and Medicaid. That's almost double, or not double, about a third more than what we see in traditional Medicare. We're seeing a lot of discussions at the state level as we have more people going on to Medicaid with that dual. The Medicare Advantage employer group, so these are individuals who are employed, and then just general enrollment, 17.5 million. If you watch NFL football or college football this weekend, which is about the only TV I watch that still has ads, you'll probably see at least 5 Medicare Advantage ads per game. At least, maybe per quarter. Maybe I'm being a little too optimistic there.
I'll trust this data also because it's from Kaiser. So the students in the room, there's a difference in coming from a for-profit company looking for how they use the data and an independent source. Just tossing that out there.
And this is 2022, so it's a little off. You can get deeper, and we're happy to share these slides. If you look at your race, ethnicity, your education level, your metro versus rural, so notice rural is a little more traditional Medicare, and then annual income. And that also is if you're in rural, there is a healthcare system. And if that healthcare system is not in network with that Medicare Advantage plan,
you lose the patient. Patient goes 50 miles away for their physician might be, but imaging, lab work, therapy, everything else is, and we've also seen a lot of steerage from the Medicare Advantage plans. You know, when there was just a handful of commercial insurance in a community, I could work with a commercial insurer and make sure we were in network and got covered and everything. Like when there's dozens of Medicare Advantage that hit the market that only have IU Health and Ascension in their plan, they won't cover anybody locally, but it's the one that the local insurance broker pitches, I lose all the patients. Even when they have, even when I've signed an agreement with them, the patients get the call, oh, by the way, you need to get your imaging, you need to get your mammogram, you need to get this done down the road at Bob's Imaging Center or something like that. They're constantly steering patients. The patients, it's not like healthcare's not confusing enough, but that adds to the complexity. And sometimes there's this, oh, you need to go there, we've checked their quality and it's very good. And it's like implying that mine isn't. It's not that that's actually happened. And I'm bitter about it or anything, but.
So we look at Medicaid. So Medicaid has been in the news a lot. OB3. If you watched and observed that around the 4th of July holiday, and what that looks like, there's a lot of discussion. Medicaid, you know, you go to any state, we don't all call it. What's Medicaid in Indiana called? Anyone know? HIP. Right? I was at the grocery store talking to someone I knew through church, and I'm like, well, I'm thinking about this and all this, and like, well, it doesn't bother me. I'm on HIP. I'm like, and what is HIP? They're like, what's HIP? I'm like, no. What is HIP? And we Googled it there in the Isle of Meyer. And I'm like, it's Medicaid. Like, this will directly impact you. Well, I didn't know that. You do now. Happy 4th of July. And I walked off and got my apple pie. But in Medicaid, we look at this federal match. So Medicaid is a federal and a state program. Medicare is all federal. We pay our federal taxes. It comes out of CMS. Dr. Oz, who is the administrator of CMS, I'm not doing a Wizard of Oz reference, but Dr. Oz, the administrator of CMS, oversees that program. Medicaid, the federal government gives money to the state, and the state also puts money in, and it's governed at the state level in our state by Family Services and Social Administration, FSSA. FSSA Administration. There. We look at the FMAP, and the FMAP is a very complex formula. In my qualifying exam for my dissertation, I had to calculus out that formula, which was fun. I'll never do that again, nor will I ever require a student to even try to do that again. But your FMAP is based off of how healthy is your population. If your population is relatively healthy, their healthcare expenditures will be lower than states where their population is not as healthy. Notice, what is the darker color here? The South and Appalachia, where we know disproportionately there are patients who utilize more health care because their health status is not as healthy as some out in the West, there in the Northeast.
And there's probably a caveat to that. They utilize it late.
Right.
It's not keeping their blood pressure, diabetes, and everything else under control. It's coming, the 911 call and the ambulance and the things that don't add to quality of life. And we always look at health data and statistics, and the battle cry in Mississippi is thank God for Arkansas, and so they're not 50th on the list and things like that. So it's not because they're spending a lot of money; they're getting a lot of good outcomes.
Indiana's FMAP is 65.34% last time I pulled it. So for every dollar of Medicaid going to a rural hospital, 65 cents of that is federal, and about 35% of that is a state match of some kind. And we heard in Carrie's presentation, OB3 will reduce that by about 21%. 3 different things. We look at who is on Medicaid and then what is the appropriate spend, again from Kaiser. So individuals eligible based on age. So those who are over 65, they create roughly nationwide 10% of our Medicaid population, 20% of spend. And what were the 3 words that Carrie said that NRHA doesn't like to use, but it's true? Rural is, what's the first one? Older. So we have more Medicaid, older individuals living in rural as a national trend. Every rural community is different. We have individuals eligible based on disability. So either a physical or an intellectual or developmental disability who have a big spend. Other adults, 20%, which is 13. The ACA expansion population, so when we expanded Medicaid under the ACA. And then our kiddos make up a huge proportion of our Medicaid population, but are relatively inexpensive as a national average. So what population is OB3 looking at changing? Well, we're not really touching the elderly or the disabled directly right now. It's really looking at these other adults, these ACA expansion adults, and a little bit with the kiddos, but they were not really directly affected by OB3 legislation. It's primarily those expansion adults. And what's one of those ways? It's the work requirement, work, school, or volunteerism requirement that is going to be implemented and required every 6 months to validate that they're in there. And how will this affect rural hospitals? Because Medicaid, and we're going to look at data here in a minute on that. If we look at Medicaid spending per full benefit enrollee across states, it varies greatly. Even though the FMAP was higher down here, notice the spend is less than $5,000 per individual. On average, Indiana, we are about $7,800 for every Medicaid beneficiary. Our state spends $7,800. 65 cents, that is 65% is federal, 35% of that is state-based. Our state is tight right now. The number 1 biggest expenditure our state has is the Medicaid program. Number 2, K-12 education. So think of how many K-12 schools are out there. Medicaid costs more than that.
It's always tough for us from the provider side, for physicians and hospitals, when the legislators in the state say, well, Medicaid costs too much. And we're sitting here thinking, it costs us, for every dollar it costs us to provide care, you pay us something like 65 cents. I know it costs a lot of money, but when you hire people to build roads out here, you're not paying them 65% of your cost. When we're building battleships and buying things for the military, you're not paying those companies a fraction of what it costs for them to build it. Yet it's okay to pay us less, reimburse nurses and doctors and hospitals and clinics less than our cost, and then complain about how much it costs. It's always a hard message for us to hear.
If we look at Medicaid enrollment over time, if we go all the way back to 2000, there's these yin and yangs. Notice we saw a dip in Medicaid enrollment. What do you think that dip correlates with? Passage of the ACA and the opening of marketplaces and the ability of individuals. And then we see some of these spikes around the pandemic, and then we'll see with the projections over time. Okay, I'm going to skip over that. I think that was a little too wonky. So let's look at some hospital rural data. So this is data that is publicly available. Anyone with an internet connection can go to cms.gov and download this data. So no trade secrets here. Really want to give a huge shout out to Ying, who is a doctoral student with the center working on this data, who's done a lot of work, and then Andrew Weber as well, who's done a lot of work on this as well. Looking at rural hospital financial positions. So this is the hospital cost report data. It's the form 2552-2010, because Medicare likes to make things a little complex, but numbers make things simple. We use the Critical Access Hospital Measurement and Performance Assessment System technical documents for the calculations that were done with this data. And data was analyzed from 2010 upwards to 2023, which is the most recent data. One of the lovely things about healthcare is our data is always lagged by at least a year, if not longer. So you're like, 2023, that feels like so long ago. It's the most recent data, I promise, okay? Actually, no, 2024 came out like a week ago, but it's gonna sit until after this symposium. So we look at margin. So each of these graphs are going to be similar. The red line is Indiana, because there are some IU alums in the center. So I will just say we chose red on purpose. And then blue is the national average. We were able, and we have produced, and we're not going to show any of this data publicly, each hospital in October when we have our report, we get each of these graphs with their hospital specific as a third line. But that'll be specifically for that hospital and that leadership team to see how they compare. We will not advertise that. Again, this is publicly available data, so if someone wants to have a fun Saturday evening, they can produce all these graphs. No last? Okay. So if we look at total margin, so this is the money left. Notice our axis is between 0 and 12%. My dad worked in the furniture industry. If I said, hey, if you have a 4% margin, is that a good year? He'd laugh me out of the room. But in hospitals, right, we're looking at a 4% margin. Indiana, we did really well. Above national average up until about 2017. We saw a spike or a dip that went actually below. So on average, all of our critical access hospitals had a negative margin on average. Now there's some outliers in there and we can tease out that data and have that discussion. We saw a spike right after the pandemic. Again, that influx of COVID dollars, CARES dollars, other funds that came from that. And then we saw that dip back down and we're actually below the national average.
And when you look at this, it's like, well, wait a minute. You're talking about not-for-profit hospitals, so shouldn't they be right there? Wouldn't that be okay? And the answer is you kind of need 2.5% to 3% just to keep up, because you can't replace your 64-slice CT scanner with a 128-slice CT scanner. You can't upgrade your facilities. You can't do things like that unless you've got just a little bit. And if you've got, which we don't call it profit, it's revenue over expenses. I don't know. If you actually pay all your go-forward capital and everything like that, then it ends up going into your cash reserves. And trust me, you have to have some cash reserves. You can't, if you have no cash reserves, paying next week's payroll can be really a challenge. And I'll stop there because I know you've got more slides.
We look at average daily census. So for those of you not in healthcare, this is it's the head on the pillow at midnight. That is when the snapshot is taken of the hospital. If I come in at 2 a.m. and I'm out by 10 p.m. the same day, you're outpatient. You spent all day there, but you're outpatient. So at midnight was your head on the pillow or in the facility. That's when one's yelling at me, I don't like pillows. I'm like, okay, never mind. Okay, if we look at margin or daily census, so a critical access hospital by law can have no more than 24 staff beds. In Indiana, we've seen this gradually decline. We saw a spike during COVID, shocker, not really, joke. But Indiana, we see a higher census on average than we do in the nation. We think of especially the frontier states, so the Montanas, the Wyomings, the rural Colorados, they may have an average daily census of 1. But they're also 3 to 4 hours away. Pretty much anywhere in Indiana, I can be in a major metropolitan area within an hour. Maybe an hour and a half if I'm in the southwest part of the state. But I can get to Bloomington pretty quick, or over to Lafayette or Muncie or Fort Wayne and get to a bigger facility.
I'll let the people in Evansville know it's not a major metropolitan center.
Hubach at Purdue.edu. No, just joking. If we look at 1 year change of operating revenue, so we look at how were you doing the year before to this year, you would hope that every year gets a little better, but sometimes it doesn't. Notice Indiana in the middle of the 2010s was a little worse than the national average, and since the pandemic, we've seesawed with the rest of the country.
I think that each state, again, if you've seen one rural community, you've seen one rural community, you've seen one rural hospital, you've seen one rural hospital. But some of these have trends the way they're set up in different states, and they are smaller. The one thing I will tell you, and it kind of goes back to the last slide, I've known hospitals where their philosophy has been to focus on growth. And how can we offer more to our community than we did last year? And those are the ones that seem to survive and thrive. The ones that are cutting services are the ones that I particularly see struggling. It's like we can't make budgets, so what service can we cut? And it's their first go-to thing. And it's tough. It's hard out there, but and unfortunately, when you're like this, you have to spend more time on financials than doing the health that your community needs. Because one bad decision, and all of a sudden now you're in the red, and now hard decisions have to be made.
So we move away from revenue to expenses and how well expenses are changing. We see that our expenses are going up over time. You would expect some of this with inflation. Things are just more expensive. A car back in 1990 was more than a car is today. But how have we compared? So we were really good at managing some of those early on, but our expenses have gotten a little heavier as a nation or as a state compared to the national average.
Yeah, some of this is just natural. Some of it's salary stuff. Some of it's new technologies. Stroke care. I work with the American Heart Association on stroke care. The medication that you've got to have ready on standby, prepared for, is not cheap. There's just so many things that play a part in it. Our capabilities are much greater. So yeah, you do have this. Some of it, again, it goes back to that reasonable cost. Are we wasteful in healthcare? Could we be more efficient? Could we be more successful? Could we negotiate better prices on Band-Aids? Yeah, there's opportunities out there. I will tell you, electronic health records play a big part in this. When you look at the budget of 2011 of what they spent on, what the average rural community hospital spent on electronic health records to what they're spending today, and believe it or not, electronic health records don't treat any patients. You can't bill for it or anything like that. So it does add a ton of cost to it. And the other thing really is what I alluded to earlier, that complexity of the billing issue of having 70 to 80 to 90 different payers as opposed to having 7. So if you go into any hospital's billing office now and compare to what it looked like 10 years ago, you'll be shocked. Even if their volume has stayed the same.
We look at salary. So what is our average salary per FTE? Now an FTE can be everything from the individual that welcomes you into the clinic and checks you in all the way up to the surgeon or the ER physician or something like that. So you have a wide spread. We see there's an increase in salary as a nation. Indiana, our labor market's a little more expensive than the national average, which for our team was a little shocking when you think of the East Coast, the West Coast, where cost of living in California or New York is much higher than that. You notice that we have plateaued 2022 to 2023, but again, that was right after a significant increase over the national average in FTE.
There's a ton that'll go into this. One, I'll kind of put you back to the inpatient volume versus the national average. So the hospitals are in general more robust. So it'll lean to more physicians, therapists as a percentile of the folks you employ. You're doing more in surgery, things of that nature. Will add to the salary. It's tough to do this because I can shrink that quite a bit. I can move my numbers all over the place if I outsource my human resources department, if I outsource housekeeping, if I outsource, the maintenance department and things like that. Then all of a sudden they're not part of salary anymore. They're part of contracted services. So this one's a little tough to so put a little bit of effort into this, but don't lock solid any decisions on this one.
So then Medicaid mix. So we talked, national average 21% reduction. Medicaid makes up a portion of payer mix, but notice in Indiana, in our critical access hospitals, we have significantly increased our Medicaid population, way more than what the national average, way more is a good statistical term, right? But way more than the national average has been. And we've seen this in this exponential curve really since about 2019, pre-pandemic.
I have to kind of look at HIP and the expansion, the way Indiana did it. Some states expanded Medicaid and it was a great thing, and some states just won't because they hate that part of the population anyway. And I'm not sure why they didn't expand, but Indiana did it, and we actually came together, and it was something we kind of agreed to. We sat down and had a good discussion about it and expanded. Under Governor Pence, we expanded in Medicaid the Indiana way. President Obama his team was okay with giving the waiver on allowing Indiana to do that. And we did it in a kind of a bipartisan way, and it was supported by everybody. So there's not this pushback to the point that people you run into don't even think they're on Medicaid, which is great. They've got healthy Indiana plan. They've got coverage they need, and it works out well, and the hospitals accept it, the physicians accept it, and the patients are good with it. So I think a lot of that, you can kind of point back to that and say, we expanded Medicaid the right way, and we're successful with it. That's the best I've got on this one. And that's empirical. That's just.
I think some of this data is also things that we need to watch. What will 2026, 2027, as the CBO's estimates of people falling off Medicaid, or, right now, really no one's coming off Medicaid. Fiscal year 26, there might be some. Fiscal year 27, a few more, but really it's fiscal year 28 and on forward. So what will this graph look like? And then this graph of uncompensated care. So these are individuals that go to the hospital. We talked about this to start, full circle. They come in, they've hit their deductible. They don't have the means to cover a $10,000 deductible. They're then flown to Indy or driven to Indy for care. Deductible has been met. That facility is now charging everything to the insurance provider, and that rural hospital is not meeting the deductible. And that uncompensated care, we've seen a huge dip of this, right? But notice the critical access hospitals, especially early 2010s, 2011s, were significantly higher than the national average. Again, another chart to be looking at over the next few years of, do we see this starting to go back up? And how do we compare to that national average?
All good points of discussion. I think, we see this 2019, we start to see this dip down significantly. It's worth a discussion. I don't know that it's like any of these things you can make a decision on. That's why I go back to that RAND report. Don't make a decision on that, but open your mind to say what's really happening here.
So where do we go from here? A lot's going on in DC. The person I normally get my information from is sitting in the back of the room, so I'm not going to even try to speculate, but we have fiscal year 26 budget. We are on the 12th of September. So we got about 16 days to keep the government open, or a continuing resolution, or if you're a fan of West Wing, a good old government shutdown. I know that probably just aged myself right there when I said the West Wing. That was like the old House of Cards, which House of Cards probably just aged me as well. But there's a lot going on, a lot to look. And we do have a lunch and learn, or a brown bag, I forget what we call it, but a webinar in November that the center will be hosting to give a little bit more of an update, knowing that we're going to run out of time today. So I take you back to the imagery at the beginning. Like I said, I love cruising. It's probably unhealthy how much I love cruising, but I love cruising. So that October trip of last year, it was fall break week. We were leaving. Anyone know what happened October of last year about this time of year? Hurricane Milton, Category 5. So we get on a boat. They're like, hey, we're going to change our itinerary because there's a Cat 5 hurricane. Thank you. You're on the boat. You got the text, hey, your airport's closed for the next 4 days. Great. I teach Monday. Let's see how this goes. But you get out. We went over to Mexico. Day ends. We're getting ready for a day of sea to head back to Port Canaveral, Orlando. You're sitting on the balcony, and this sunset starts to appear. And everyone else with us, with a big group, we're all like, okay, we're just going to sit here for a minute and enjoy the sunset. And then one of the people I was with made the comment, he goes, isn't it amazing the beauty that comes from destruction? And I thought, wow, we are preparing for maybe nearing the eye of the change of rural healthcare in this country. Massive destruction will occur during this period of time. I'm not going to get up here and say everything's going to be fine, no harm will be done. But at the end of a massively destructive hurricane, Cat 5 can't get any bigger than that, I don't think. Again, not Earth and atmospherical sciences. Was this pure beauty. The water was calm, and everything returned back to the way it should have been. And right now, I think as we look at healthcare, specifically rural healthcare, we're going to ride the waves for a while. We're going to do some surfing. We're going to drink a lot of salt water. But at the end, hopefully the beauty will return because our communities depend on us. They depend on the providers that are out there that do the work every day, and without them, without people like Tim, they won't be there.
You got to think in every small community hospital, health clinic, and things like that, the board's sitting there hearing what you're hearing going, ugh, because the decisions I make are going to impact my family, my friends, the people I care about. The one thing we need, and what I tell them is, you can no longer do things the way you used to do them. You will not survive in this coming environment. Too many forces are aligned against you, whether the insurance companies' data is correct, or they're getting momentum on that, and they are paying significantly more than the government, and they're ticked off about it. And they're not going to stop until they're happy with it. And that's a long way from now. The government's upset about paying as much as they are on health care, and that's not going to change for a while. We've got to figure out how this dynamic works and how to function in it. And it's not going to be doing what we did 10 years ago just a little bit better. And you need to have new discussions, and how do we honestly do that? How do we fully engage? How do we get people to work at the top of their license? How do we use machine learning, AI technology, new ideas from people that are not bogged down in the paradigms that we're in? I mean, it is a paradigm change that we need. It's not just doing what we used to do a little bit better. It's really different. So there needs to be new voices, but there needs to be people in small communities stepping up and engaging and recognizing this. And I'm a little bit concerned that many of them aren't. That they want to go back to the way it was 10, 15, 20, 30 years ago, and that's the answer. And that will not work. So the ones that realize that and engage in those discussions, I think, are going to be okay. The one good thing, and I'll pitch Carrie's organization of one to stay in touch with, is they're very good when they find something that works in one community, it has a tendency to spread a little bit. We did this and it worked. We did this and this functions. We can do this. We can do a mobile MRI program. We can set up a telestroke program. We can do this with our EMS. And they can spread it out. And again, it's kind of like that ski boat as opposed to a cruise ship, not to put cruise ships down. But they can move faster, they can turn quicker, and when they have a good idea, when my medical staff would get a good idea, it would be implemented within 24 hours. It would buzz around, oh, let's do this. Oh, okay, we'll do this. Okay, this is what happens in all our ER patients that come after 7 o'clock that need to be admitted, and we'll do this, and we're good with it. Like, okay. That's the kind of stuff, but we need to be agile, mobile, and hostile. Okay, maybe not hostile, maybe a little hostile, but agile and mobile first.
So this is where we want to turn over to discussion with the room. We have a lot of different, we have community stakeholders, we have faculty, we have staff, we have students in the room. We all bring something to this because we all interact with healthcare. So what does this all mean? What's the next step? I'll also say for community members, if any of the data we showed, if you want to know your specific facility or anything like that, let us know and we're happy to get that to you. But we don't make that publicly available for multiple reasons. So discussion, questions, pushback. And there's a mic that we're going to float around.
Sure, I'll do that.
Yeah, I'm a former cheerleader.
Oh, we need it for the recording.
You have to yell in the mic.
Oh, you don't want me to do that. My question is about the slide on the HIP differential between Indiana and the nation. Of course, as I remember it, sort of in my seat at the state health department, the HIP plan was started by Mitch Daniels and Dr. Monroe, and they built that on the basis of the money came from cigarette tax increase, and so it actually preceded Mike Pence by a little bit. So I'm guessing from your remarks that Pence just kind of took what they built. Yeah. Yeah. But the thing is, the word on the street was always, from my social work days, was always, it's hard to get on Medicaid, but once you get on Medicaid, it's really good, you know? Yeah. And so the coverage was great, and I think you kind of alluded to that. And so my question is, how does that affect that disparate spread between nation? I mean, is the fact that our Medicaid just pays really well? Is that why we're so high, much higher than the national average, or something else?
The HIP plan existed under Mitch Daniels.
Right.
But there weren't that many people on it.
Okay, because it's supplemental.
Yeah, it was a supplemental. It was a narrow niche. If you didn't qualify,
didn't it include working families as opposed to just single parents and children?
It was kind of there. When I looked at my hospital, I accepted HIP patients, but very few of them entered my doors. Mm-hmm. Now, here's the story that Mike Pence told me. And it has to do with the HIV outbreak in Austin. And Jerome Adams can tell this better than I can. Mm-hmm. But what happened is there's this outbreak in this time, and many of the people were not covered.
Right.
But they would have been under the Affordable Care Act Medicaid expansion. Mm-hmm. But Mike's a Republican, and the Medicaid expansion was through a Democratic president.
Oh, so it's political? Is that what you're saying?
It was political, but he said, let me do it our way, basically to President Obama. You've got to let me do it our way. And we had this HIP program as the vehicle. Let's expand it through HIP. I'll get it done.
Okay.
And he says that's the conversation. And with President Obama and then with his team, we expanded it through the vehicle we already had, which was HIP.
Which was HIP. Okay.
Which was a perfect vehicle for it, and the acceptance was good. So you've got Governor Pence going around the state promoting Medicaid expansion as a Republican in this Democratic program because we did it our way. We did it the way we wanted, the way he could support, the way he could stand up to his constituents and say, this is the way to do it and do it right.
Well, what would explain that why is our Medicaid trajectory way higher than the national average? Why is that?
So when Medicaid expanded, when HIP 2.0 is what we called it, expanded, The FMAP of that ACA expansion was not your normal FMAP. It was 90 to 95 cents federal, 5 to 10 cents at the state level.
Okay.
So the states were like, okay, we're going to pull down a lot of federal dollars very early on with this program because the feds are matching so much higher. And that was part of the push of HIP 2.0 was let's get these federal dollars into Indiana with very minimal state investment to level off and try to, anytime someone uninsured goes on insurance, there's a lot of care that's delivered those first few years, and then hopefully the spend comes back down as it's more of a maintenance mode instead of that initial workup diagnostic mode.
Okay.
And there was also, and this is a point that I think is important because there was willingness by the state to help get people that needed it, that wanted it, that qualified for it, signed up for it. So there were good processes, and they came out to hospitals and say, help us sign up the right people for this, and here's the way to do it. And it's one of the things I worry about with you have to re-sign every year for the different plans and things like that. If that becomes more complicated, how many people that deserve it are going to receive it?
And that's always been a problem with Medicaid as well, is the bureaucracy of how to maintain your services and people being kicked off and then having to reapply. And, that's been a struggle, I think, for
There's a lot of things that can be successful when everybody gets behind it.
Yeah.
And with that HIP 2.0, which was what it was called,
Right.
everybody was behind it. Everybody was behind it.
Yes, they were.
The state has helped with the recertification from personal experience. They now have a portal. And I thought, oh, great, the state has a portal. It's great. It's absolutely great. But I also know this year when I had to recert my brother, it took me 4 days and 2 attorneys to help me do it.
Yeah.
I have a PhD in health policy. I should be able to do a basic recertification. And the forms are so complex.
Right.
And the cost, if you mess it up, is so great that, that adds to the stress of, okay, I read it this way, but it could be this. Let me call my friend who's an attorney. It's like, well, I don't know. Let me call my friend who's an attorney. And you start this whole, and they're like, okay, if we can't figure this out, how can my neighbor
Exactly.
who is well educated, but they're school teachers, how do they figure it out?
Or people who don't have any education or have, cognitive issues, who are often in that situation.
Yep.
So where does this go?
Anyone else have a question?
Next
Discussion?
question. Love to hear from the students or whomever.
I'm just curious your thoughts on how impending tariffs might affect some of this with possible increases in drug and prescription prices, like new technology prices, or will that play into this at all?
From my standpoint, it's one of those things where it's going to limit access to some technologies that would benefit. So if we are moving toward technology improving it, AI capabilities, machine learnings, and things like that, if we don't have the technology access to the world, that's going to inhibit, or it's much more expensive for us. I don't see anything in the tariffs that help the situation at all. I'd like to look for some silver lining. I just don't see it, and maybe I'm just not looking long term enough. I mean, the idea is you'd like to see, during the pandemic, we realized what things we couldn't get from offshore, and onshoring was a big deal. I'd love to have the plants that manufacture everything I need right next to me. I don't know if that's going to happen with the tariffs. I've got enough of an economics background to know that world trade is a good thing. But I also know that I was short on some stuff that I really, really needed during the pandemic, and I don't want to see that happen again. So that's about the only silver lining, if it encourages more product to be accessible and domestically produced.
And we also know factories, not my area, but factories, land is more accessible in rural. So if I'm going to build a new factory and I need 300 acres of land to do so, I'm not going to come to Indianapolis to Marion County to get 300 acres. I'm going to go to, a rural community, and maybe that will get a younger population into that community and that workforce.
Oh, yeah. Here, take this.
So I'll speak to your question. I work in West Lafayette for a contract research organization, and we work with companies all over the world with new product, new medical device, and biologic innovation. And the tariffs are already affecting things right now. So we've had clients back out of big projects because they just simply can't afford to move forward. And it also affects clinical research, which is what I'm in charge of. So if clinical studies can't happen, we can't keep products on the market, we can't get products on the market. So we're already seeing the effects, and it's only been, what, a few months?
I have a
And the bright side? Okay, well, we'll get back to you.
I have a two-part question for you, Mr. Putnam.
Yeah.
I guess the first question, I did bring some students here today, some nursing students who are going to be graduating soon. Do you have any thoughts on how this will affect them, and then also how they can advocate for themselves and their patients?
Okay, well, sign up for Carrie's organization, and she'll help give you the language of who to speak to and why. And I strongly encourage you guys to have a voice, and that your voice means a lot. You've got a long career in healthcare, and you're in it for the right reasons. And legislators are moved by what you have to say. You can be very impactful. So it's important to raise your voice, and this is what I'm concerned about, and this is what I want, and this is what you need to hear from me, and I will be the one taking care of you when you really need it. I will give my pitch for rural healthcare. When you go into rural field and you take care of patients that you know, that you went to school with, that babysat for you, that babysit for your kids, that you'll see every day, it is more rewarding than any career out there. You're making a difference for the people you care about and will see on a regular basis. And this is kind of, you know, from the EMT in me, not the hospital administrator. When someone is scared to death and comes in the ER and sees your face, and they go, "Oh, thank goodness you're taking care of me," the value you get out of that is just incredible. There's nothing like it. Same thing happens in Indianapolis or larger communities, but you never see the outcomes of what you did. You never know the lives you touched. And in rural areas, you really get a chance to do that. So if you have the ability to work in a small community, work and live and thrive in a small community, the rewards are incredible. I can't imagine a career that, I mean, a lot of people have a career and they like it, but you'll hear them talk about other things that they do in their life. When you're engaged in this type of thing and you're in it for making a difference for your friends and families and neighbors, you can really do it. The other thing is, the ones that will be successful in this field, stay up to date. I know you're tired of studying and tired of learning and just want to go out there and take care of people. But your field is going to move fast. And you're going to be asked to work at the top of your skill set and use all the capabilities that you have. That is very important for you to stay up to date on that, advance your learning, advance your capabilities, advance your certifications, so you can bring everything, whether you're rural or urban, so you can bring everything to the game that you have. It's tough, it's difficult. I will tell you, when the pandemic broke out, my community was hit very hard, very quickly. We were one of the hot spots early on. And the courage I saw with the nurses, we didn't know much about the disease, but we saw people coming in and die. We saw people come in and struggle and die and scared to death. We didn't know how it was spread. Our first patients came in with gastric issues, upset stomach. And when we did the x-rays, we saw the bottom of the lung and like, oh my gosh, what's going on here? And I saw people step up and be heroes like I've never seen in my career. Like only when I was first working with AIDS patients did I see that. And you know, the bravery that these people have, you will face that in your careers. There will be some unknown disease that'll hit and it will not be like COVID. And one of the things we said during COVID, this ain't your grandma's pandemic. And yours, the one you'll face, will not be. You better be ready for it. You better be trained. You better be educated. I mean, you'll make an impact. And with that impact comes heavy responsibility. So I'm proud of you guys for stepping in this field and doing this and being there to make a difference. And it's going to be a ride. You'll always be in demand. Nurses are thought of as the most trustworthy profession out there. You get a chance to earn that trust and use that and make a difference for people. That's rewarding like so many other careers will never be. Is that close? Okay.
Feel bad saying other questions after that, but other questions? I see one over here. I don't know where the mic. Oh, thank you.
Thank you. Hi, I have more of a comment than a question, and it definitely is on the pessimistic side of things, which is I've been talking to a lot of people who work in health departments and in health department leadership, and one of the things that I've been hearing from them is it changes so fast, I don't know how to respond to it. And it being everything happening at the federal level, happening at the state level, with laws, with policies, with executive orders. And so I hear that we're in the eye of the hurricane and that we're going to get through to the other side and it's going to be smooth sailing again one day. But if we just keep bouncing back and forth between the eye of the hurricane and being right in the middle of it, I mean, I think that's one of the big challenges that we have right now is that, there are I had people who say to me, today, I found out that my funding for such and such ended yesterday and people showed up for work today and I couldn't pay them. And that's, I've heard that many, many times.
Very close to the eye of a hurricane, if you watch what happens, there are several tornadoes right outside in what we refer to as the eye wall, where the winds are the highest and tornadoes are formed. I think that's kind of where we are. It's a hurricane and there's a 120 mile an hour wind, but then there's a tornado that comes in with a 200 mile an hour wind that comes whipping through here when we were prepared for only 140 mile an hour winds. And then it goes away and then something else and the rain squall comes in, the storm surge comes in. That's kind of where we are. I cannot tell you when it'll settle down because so much of what you're saying ties to funding. When, and so much of what we do in hospitals, and I've made several comments about making payroll next month. The more I know what the rules are, what my income stream's likely to be, the better I can plan for the future. And right now, it's really tough to plan for the future. And I don't know what to tell you, but it feels like we're right in that eye wall. So you're not in the eye of the hurricane. That's peaceful and calm, and it looks all nasty around you. The eye wall's where the action happens, and I think that's where we are.
Not a shout out to join NRHA yet again, but I also encourage you joining a trade association. If that's rural health, if that's public health, if that's healthcare administration, and having those discussion boards and those peers. We don't have the answers in those discussion boards, but it's so refreshing at 8 p.m. to see 30 emails in NRJ Connect of people struggling with the same stuff. And there are some nuggets of support there, but just knowing, hey, it's not just me.
And do everything you can to keep from being blindsided. That doesn't mean you won't get blindsided, but stay in touch with your local state rep, stay in touch with your local senator, get engaged, make sure your voice is known. Indiana Rural Health Association, National Rural Health Association, everything you can do to keep from getting blindsided. Doesn't mean you won't get blindsided. It's just when you are, you'll know you've done everything that's in your power to do that. So, sorry. Yep.
Thank you.
Eye wall analogy is all I got.
And thank you both. I think on to Catherine's point is we know, and we've talked a lot about the healthcare sector, but just the larger public health sector in general is what we know public health to be is no longer, and it will not be like this. And so it's not we will have to be like a phoenix and rise again and rebuild it. the CDC, HRSA, SAMHSA, every organization that has funded the work that we've done will look vastly different. And if certain things happen with funding and we do go into AHA, then it's really going to be
Well,
a show.
and I'll tell you, adapt to the language that's important. So when you hear somebody like Carrie talk about a meeting with Dr. Oz or what comes out in the Make America Healthy Again plan, align what you're doing with the language that's coming out for what they'll support. And when you meet with your local representatives, senators, the governor, whomever, couch it in that language. We're trying to accomplish this. That is an important part of the administration. Help us do that. Don't cut our funding for this because it's being used specifically to make America healthy. Best I got there.
Other questions? Well, hopefully Purdue wins tomorrow because I'll be more cheery than this session. Or at least beats the spread. Well, thank you all for coming on this Friday afternoon. Thank you for the discussion. Thank you, Tim, for being the discussant of the presentation. We got about 8 minutes, and then we're going to reconvene in the main room where we started this morning, and we'll have a wonderful close up by Dr. Hubach, who will summarize and close out our day and all that. If there's anything we can do with anything we discussed today, please don't hesitate to reach out. And there is my email. So, thank you.